دكتور دكتور عبد الغني اتفضل.
Okay, it's great pleasure to introduce Dr. Mahmoud Bushra this presentation. Dr. Mahmoud طبعا he is known to most of us, most of the trainees as well. He's a consultant in old age psychiatry in Birmingham, UK since 2004. He is a Royal College tutor. Dr. Mahmoud has graduated from University of Khartoum. He's got MBBS. He also got DPM in Ireland from the conjoint board of the Royal College of Surgeons and Physicians in Dublin. He's a fellow of the Royal College as well of Psychiatrist, UK. Dr. Mahmoud is an examiner for the Royal College of Psychiatrists in the UK. He worked as a president of the Sudanese Psychiatrist Association, UK and Ireland, from 2011 to 2021. For 10 years, Mahmoud كان الرئيس جمعية اختصاصي الطب النفسي السودانيين بالمملكة المتحدة وإيرلندا. غني عن التعريف محمود بشرى. He is one of the pillars of psychiatry وواحد من أكبر الداعمين لمجلس تخصص الطب النفسي ومنظمين لكل المؤتمرات اللي عقدناها من 2011 لحد 2023 في السودان والورك شوبس. سنويا بيحضر ويدرب كل المتدربين اللي دلوقتي كان حاليا كونسلتنت في عدة دول. محمود بشرى شارك في تدريبه من حقيقة هو وعظمة وبعض الإخوة الآخرين من UK ودول الخليج. وحقيقة الكلمات تعجز عن وصف محمود أو أداؤه أو ما قدمه لوطنه حقيقة. فزمانهم وإجازاتهم تطوعهم كله كان عمل تطوعي ويكتمل العمل. واليوم زي ما كلكم عارفين دي المحاضرة الأخيرة في الفيرست 2 months of 2025. ودائما أقفلوا المايكات يا شباب. بيشاكل في ولدها أظنه. المهم فزي ما بنقول ختامها مسك. فمحمود بشرى the platform is yours and the mic is yours. تفضل.
شكرا جزيلا دكتور عبد الغني. سامعني كويس اخواننا؟
جدا سامعينك.
شكرا جزيلا عبد الغني على المقدمة وما كانت متوقعة يعني. ويعني شكرا للحضور جميعا. وانا الحقيقه داير ابدا بانه يعني انا حتكلم في الحقيقه يعني جزء عربي جزء انجليزي عربيزي زي ما بقولوا يعني عشان سهوله الكوميونيكيشن. انا الحقيقه داير في الاول يعني ابولوجايز انه انا ما قدرت اشارك في المحاضرات دي من الاول لظروف كثيره يعني خاصه وعامه. والحقيقة عايز أشكر برضو بالتحديد دكتور عبد الغني، لأنه أنا أي نو إنه من مقامة الحرب دي اللابتوب بتاعه ما فارقه، وسواء كان في السودان ولا كان في الإمارات أو كان في إنجلترا أو كان في مصر ولا في أي مكان.
لا سمع هذا يا رسول.
كان مهتم بأمر التدريب وأمر المتدربين، وحتى يعني في الآخر كللت مجهوداته بأنه يتم الامتحان الفاينل بتاع الترينيز ويتخرج أعتقد 23 من في بورسودان، وله الشكر الجزيل. وهو كما عهدناه يعني هو برضو كان واحد من البيلرز بتاع التدريب في السودان في السنوات الأخيرة، ولولاه هو نحن ما كان الشغل بتاعنا اللي عملناه في السودان كان بيتم. فشكرا جزيلا لك يا دكتور عبد الغني على كل ما قدمته للتدريب في السودان. وشكر ثاني كمان هي ما أقدر أقول الأخ ياسر، المفروض أقول الابن ياسر، لأنه عرفت إنه ياسر اتخرج سنة 2007. 2007 ليه بيكون
الحفيد ياسر. طيب نحن بنقول له الحفيد ياسر.
الصغير في سنه لكن كبير في
يا
أدائه،
سلام
حاجات
يا
العمل يعني.
سلام
وأنا عرفت
يا
إنه هو
سلام.
دينامو وراء كل هذه المحاضرات تمت في الفترة الأخيرة يعني. وشكرا للحضور برضه. طيب أنا هتكلم في الحقيقة يعني يمكن العنوان شوية كان فوق كونفيوجن. أنا هتكلم عن الزهايمر الديمنشيا بس لسببين. السبب الأول إنه الزهايمر الديمنشيا نفسها موضوع كبير جدا، وما ممكن نوفيه حقه في أقل من ساعة يعني. الحاجة الثانية إنه الزهايمر ديمنشيا هي ذا كومونست. يعني بعدين لما نشوف الستاتستكس إنه 3 من 4 ناس بتشوفوا إن أنت بديمنشيا بيكون عندهم الزهايمر ديمنشيا، إما ديمنشيا الزهايمر ديمنشيا بيور ولا الزهايمر ديمنشيا ويز فاسكر ديمنشيا اللي هي بنقول لها ميكس تايب ديمنشيا. فأنا هتكلم عن الزهايمر ديمنشيا الليلة، وممكن لقدام في المستقبل نتكلم عن ال other types of dementias إذا الناس حابين يعني. ف what is dementia؟ هي dementia is يعني umbrella used to describe the symptoms when the brain is affected by a specific disease and conditions. واحد منهم طبعا الزهايمر disease. طبعا في فرق يا اخواننا بين الزهايمر disease والزهايمر dementia. الزهايمر ديزيز بيبدأ في الأول ومرات بيكون ما بيعمل أي سيمتومز، لكن لما يستفحل ويزيد بعد ذاك it causes الزهايمر ديمنشيا. والديمنشيا is more than just memory loss. It affects memory, it affects the personality, and also it affects the behavior of the patient. The carers of somebody with dementia will tell you, it is not the loss of memory that affects them. It's not the thing that they find most difficult. It is the change of personality and the behavior. وأي زول عنده واحد قريب وكان عنده dementia will know الحاجة دي very well. بيطلع من البيت ويعمل يعمل لهم مشاكل ويشاكلهم وكده، ودي بتكون the more difficult part أكثر من أي حاجة تانية، أكثر من الميموري. It is progressive. Once it starts it does not stop. ودي حاجة برضو لازم نكلم بيها البيشنتس من الأول عشان يكونوا عارفين البيشنتس والكيرز بتاعهم الفاميلي. It's incurable in most cases، لكن هنجي بعدين نعرف إنه دلوقتي في بصيص أمل إنه ممكن يكون في possibility بتاعت treatment. Terminal it means إنه it is progressive and it's patients will remain with the dementia until they die. في حاجة هنا لازم الواحد to mention it إنه people die with dementia not of dementia. يعني dementia doesn't kill people. The patients die with other illnesses, in particular respiratory infection, pneumonia. ما أعرف السطر الأخير ده واضح ولا لا، لكن الديمنشيا is not a normal or inevitable part of aging. بمعنى إنه ما أي زول يعني لما نكبر بيجوا dementia. The fact is إنه most people when they get older they don't get dementia. About 90%, even 95%, they live their life without having a dementia. So it's not something inevitable, يعني, which means that anybody who becomes older is going to get the dementia. The types of dementia, as I mentioned before, Alzheimer's disease, the commonest. Other types include vascular dementia, mixed dementia, which is Alzheimer and vascular type. Then we have the dementia with Lewy bodies. Then we have the frontotemporal dementia, Huntington's diseases, HIV, and other rare types, which, like I said, we might be able to cover on another talk. So this is just some statistics about the prevalence of the dementia, and if you can see here, this is the people below the age of 65. Above the age of 65, almost half of the patients with dementia have Alzheimer's dementia, and almost another 25% will have vascular dementia and Alzheimer's dementia. So mixed type dementia. So if you add the two, you will find that it comes to about 70% or even 75% of all patients with dementia. And that's what I referred to earlier, that out of every 4 patients you see with dementia, 3 of them will have Alzheimer, either on its own or mixed with the vascular type. All the other types of dementia is about 25%. Okay, where does the name come from? The Alzheimer was this person here. You can see his picture. His name was Alois Alzheimer, and he was a doctor in Germany. And in those days, the doctors do many things. So you cannot say he was a neurologist. You cannot say that he is a psychiatrist. You cannot say that he was a pathologist, because he was all of that together. So he was running a unit in Munich, in Germany, and in 1906 he saw this patient. Her name was Augusta Dieter, and she was 57 years old. She presented to him with symptoms of confusion, forgetfulness, and psychotic symptoms. She was having visual hallucinations, she was having paranoid delusions, and she was very, very aggressive. And she came to his hospital, and he treated her, and she died in the hospital. So what did he do? After she died, he dissected her brain himself. And he looked at the slides under the microscope. And he saw certain changes in the brain of this patient. And those changes are still to this day the pathological hallmarks we depend on to diagnose Alzheimer's dementia, which is the amyloid plaques and the neurofibrillary tangles. We'll talk about it in more details later on. أنا saw الأوفيس بتاعه في ميونخ، وكانوا عاملين له زي ميوزيوم كده، وكان فيه حتى الميكروسكوب اللي استعمله هو، وحتى السلايدز الأساسية الأولانية اللي عملها كانت ما زالت موجودة، وكانت ديك أول مرة somebody to describe the illness. He didn't call it Alzheimer's dementia. He didn't call it Alzheimer's disease, sorry. He died very young. He died when he was 42 with a heart attack. He was on the train to Berlin to attend the meeting, and he died on the train. And after his death, Kraepelin called that illness Alzheimer's disease in memory of Alzheimer himself. And that's the history of where the name comes from. So these are some people, some famous people who were diagnosed with dementia. And as you can see here, President Reagan, and this is Charles Bronson. People from my generation will recognize him immediately. He was one of the most famous characters at the time. This is Harold Wilson, who was a prime minister of the UK. Rita Hayworth, who was a famous movie star. He's an American boxer, I don't know his name. And also to add to this list, Mrs. Margaret Thatcher, who was the prime minister of the UK for 18 years. And what that means, nobody is immune from the dementia. Doesn't matter how much power you have, how famous you are, how much education you have. And we all know that some of the eminent doctors in Sudan and in other places did succumb to the illness. And in my experience, it's an awful illness. I personally, I think that it's worse than cancer, because the patient with the disease just becomes an empty shell. This is how they're described, an empty shell. They are not the same person anymore. If people remember, when President Reagan was diagnosed with the illness, his wife, Nancy Reagan, he didn't allow anyone to see him or to take pictures of him. He just wanted people to remember him as he was in this picture, not to see him when he was in the advanced stage of the illness. So the prevalence is about 5% of people above the age of 65 will have Alzheimer's dementia. And this will increase by about 1% every year. So by the age of 80, about 20% by age of 90, it was about 25 or 30%, and so on. However, it doesn't go on like in a linear progression. We noticed that after the age of 90 or 95, the curve plateaus. We don't know why. And this came from statistics in Scandinavia. You know, in Scandinavia, people live longer. So the average life for men in the UK, I think, is about 70 years. For women, it's about 72. In Sweden, it's 90. So people live much longer because they have a very good health services. They look after themselves. They run, they jog, they exercise, they eat healthy food, and they live longer. So what is noticed is that after the age of 90, the curve goes straight. It doesn't keep going up. Why? We don't know. But it seems like the human body finds a way to protect itself after that age. So like I said, it's about 60 to 70% dementia in the UK. What are the risk factors? Old age, of course. Dementia and cancer are diseases of aging. And anyone who is becoming older runs a higher risk of getting cancer or dementia. Also, family history. We know that we'll talk later about a specific type of familial type of Alzheimer dementia, which is worse. Female gender, it's more in women than in men. The education level, it was also reported that people with higher education level are less represented in the population of Alzheimer dementia for some reason. There is one type, as I mentioned, which is called the familial Alzheimer dementia, or the early onset. And usually it starts before the age of 65. In the UK, we consider any diagnosis of Alzheimer dementia before the age of 65 is that type of early onset. And it's autosomal dominant. That is how it is inherited through the families. And it's more virulent, more aggressive, and patients usually deteriorate very rapidly. The youngest patient I have seen with this type of dementia was 53. And within 2 years or 3 years, she deteriorated very rapidly and she had to go into care, and she was not able to do anything for herself. Also, another observation is that the later you have the MS, the slower and the less aggressive the MS is. So people who develop it in their 80s do better than those who develop it in their 70s, and so on. And this is how it is inherited and non-familial, like I said, due to other mechanisms. This is again a graph of the representation of different types of Alzheimer dementia. So 1%, I don't know if you can see this, 1% of people with dementia have trisomy 21, which is Down syndrome. And we know that people with learning disability with Down syndrome, they develop Alzheimer dementia by the age of 35. So for some reason, they develop it a lot earlier, much earlier than the rest of the population. The 5 to 10% are the autosomal dominant Alzheimer dementia or the early onset dementia, and the rest are 90 or 95%. We don't know the etiology or the exact pathology why people develop the illness yet. However, there are two hypotheses of why people and how people develop the Alzheimer disease. One is that there is amyloid precursor protein, or APP. And I want you to remember these terms because many things relate to this later on as in the management and the treatment. So what happens is that there is accumulation of fragments of the APP in the brain, and that lead to the formation of the plaques. which kills the neurons. And that's what it does. That's what all dementia does. It kills the neurons. It kills the brain cells. The other theory is about the tau protein, tau proteins, which makes the fragments of the amyloid precursor stick together, leading to the breakup of the microtubules, and this caused form the neurofibrillary tangles. We'll talk about it in more details later on. So this is a normal cell. So this is the cell interior. This is the cell membrane. This is the APP. This is a molecule. This is a healthy molecule. This is how it is in healthy people. And what happens in Alzheimer is this. Some enzymes will cleave or cut the proteins, and those cut parts are called the beta amyloid. And when this beta amyloid, the tau protein make them stick together, causing them to lump together and cause the plaques. That's why we call it amyloid plaques. And this leads to the death of cells at a later stage. So the brains of people with Alzheimer disease, there are abundance of plaques and the neurofibrillary tangles. And these are the findings that Alzheimer found in the brain of his patient. And this is still to this day is how we this is how the definitive diagnosis of dementia, of Alzheimer dementia is done. Of course, this is not possible in a living body, in a living human being. So we do it post-mortem. And that's what we find. That is still the way to confirm the diagnosis of Alzheimer disease and Alzheimer dementia to this date after over 100 years. So this is just a summary. This is a normal APP. This is how it's cut or cleaved by enzymes, and this is the plaques formation. This is the neurofibrillary tangles. This is a healthy cell. This is a neuron. These are the dendrites, and this is the axon. And as you can see, it looks healthy. This is how it looks when it is diseased and it starts to die. And then that is released in the brain and forming the plaques. Sorry, the neurofibrillary tangles. This is how it looks under the microscope. These are the neurofibrillary tangles, and these are the plaques. Collection of APPs. Again, neurofibrillary tangles and the plaques. Some people believe that the plaques are the body of the neurons, the remnants of the dead body of the neurons, and these are the axons. And this is a section from the hippocampus, and we'll talk about the hippocampus in a bit. So the hippocampus is we think that it's the site of the memory in the brain. This is where the memory is kept and the function of it. And no wonder it's the first part of the brain to be affected in the Alzheimer disease and Alzheimer dementia. It's entorhinal cortex and the hippocampus. Then it goes to the temporal cortex, and from then it goes to the parietal and frontal lobes. الليلة عندنا طبعا a lot of neuroanatomy و biochemistry. This is again the beta amyloid and the tangles, and this is its pathway through the brain, and then it spreads to the other parts of the brain. This is a cross section of the brain, and if you remember your neuroanatomy, the small pyramidal cells, then the granular cells and large pyramidal cells, And in the this part here, these are the plaques. This is where the neurons are, and downstairs are the axons, where or the neurofibrillary tangles. And dementia, the Alzheimer dementia is one of what we call cortical dementias. And these are the dementias that affects the cortical part of the brain. There is another type called the subcortical dementia. We'll talk about it later on, which is different in presentation and symptoms and signs. So this is just a graph to show this is a healthy adult brain, loads of neurons, very healthy axons, very healthy and abundant dendrites. This is a brain of an old person. So when we get older, we get less number of neurons, but it's still healthy. We believe there might be about 100 billion neurons in the brain, and we lose about maybe 5 million, something like that every year, which is nothing compared to the large number of the neurons. So even when you are in your 80s or above, you know, you have lost, say, I don't know, 20 million, 30 million, it doesn't affect you. It doesn't affect your memory. But when you come to somebody with dementia, whatever types, this is what happens. So in a way, the dementia is acceleration of the aging process. So rather than losing 50 million neurons in a year or something, you lose a billion or something like that. And by the end, very few left, very few neurons are left. And that affects the brain and the functioning of the individual. This is again the microscope. This is a healthy neuron with the neuron body and the dendrites. You can see it rich and plenty of it. And this is what happens in Alzheimer. Very few. Again, normal brain and a dementia brain. That was the macroscopic changes. What happens on the macroscopic? If you take a cross section in the brain, this is what you see in a normal person. You can see the sulci and gyri. They look thick, and the brain itself is bigger. If you look at the ventricles, if it's normal size. If you look at this part here, it's again full. If you compare it to somebody who had Alzheimer's disease, the brain itself is much smaller because there is a huge loss of brain tissue because the neurons have died. The ventricles are enlarged, not because there is fluid, but because there is less brain tissues. And if you look at this area here, this is where the hippocampus is. And if you compare it with this one here, you can see the difference. And we look to that into more details in the next slide. So this is again normal brain, mild Alzheimer's disease, and this is severe Alzheimer's disease. You can see the changes that I mentioned. So how do we diagnose Alzheimer's dementia? One is the brain imaging, and the easiest and the simplest is the CT scans. And in my experience, the CT scan is the best to diagnose Alzheimer's dementia. You don't need more sophisticated techniques. And if you do it carefully and in the right way, you can see the cortical atrophy. Again, that is non-specific. But specifically, you will see the atrophy in the parietal and in the temporal lobes. And in particular is the hippocampus. MRIs, SPECTs, it can help, but is not specific to Alzheimer's dementia. And we'll see more pictures of it in a minute. So this is what you see in the CT scan. Again, this is the healthy brain. And this is the brain with somebody with Alzheimer's dementia. And if we look at here, this is the hippocampus. And as you can see, it's much smaller compared to the normal one. And this is a series of CT scan taken for somebody with dementia. This was in 1993. This is a hippocampus already starting to shrink and atrophied. Fast forward 4 years later, 1997, and it's even smaller. Fast forward another 4 years in 2001, and it's much, much smaller. And this is something that we use in the diagnosis, making diagnosis of Alzheimer's dementia, as you can see here. So what we do, we measure the normal, the healthy hippocampus, and we measure the height and the width and the thickness of the normal hippocampus in normal people. And they do this for thousands of people, when men, women, different ethnic minorities, and they log the results. And then they compare the finding of your patient, and they use certain algorithm tables to decide whether that hippocampus in this patient is atrophied or not. And they can even give you the staging of the illness itself. So in the prodromal dementia before the symptoms, there is 15% is mild dementia, 25% in moderate dementia is 40%. And this is one technique that we use now to diagnose Alzheimer's dementia in patients. So we asked the radiologist to take a CT scan, but you have to tell them first that this is what I suspect, that I think my patient has dementia. So they have to tilt the table before they take the CT scan in a certain way so that they can focus on the hippocampus. And then they can give you a good picture of the hippocampus, and you can see that it's atrophied. And like I said, you can use the tables to measure exactly how much atrophied it is. And that will help you to confirm the diagnosis and even decide about the stage of the illness itself. PET scans, yeah, it can help to some degree. This is a PET scan for a normal brain. And as you know, the red means that there is activity, there is good perfusion, there is good oxygen level here, and a lot of activities, mental activities. That could be thinking, that could be scanning, that could be talking or hearing or whatever. And it is marked by these red areas here. The cold is less activities, and if you notice, these are the ventricles. This is a PET scan of somebody who's 80 years, but they don't have dementia. So as you can see, there is some differences, but not huge. There is still a lot of red areas here and here and here and here, but less than somebody who's 20 years old. How does that compare with somebody who has dementia? This is the normal PET scan. This is somebody with dementia. As you can see, very few red areas and a lot of cold areas, meaning that there is no mental activities here in the most part of the brain. This is the normal brain. This is early Alzheimer. This is late Alzheimer. And this is the brain of a child. So you can compare the brain of a child to the brain of somebody with advanced Alzheimer's dementia. And this is what I was saying earlier, that the patient with Alzheimer's dementia or other types of dementia becomes an empty shell of themselves. All their experiences, all their knowledges, everything they have learned through their life is gone. And they become just like a child, even in their behavior. So these are the ways to diagnose Alzheimer's disease or Alzheimer's dementia. Structural imaging, we talked about CT scan, we talked about MRI, we talked about PET. There's also other ways, which is the CSF biomarkers. And if you remember, we talked about the APP and the tau proteins in the brain. And there is a way, of course, we can't open somebody's brain and have a look at it like what we do is in postmortem. We can look into under the microscope and decide, look for the tangles and the plaques, but we can't do that in a human, in a live person. So where else can we find or check for the plaques? in the cerebrospinal fluid. So you do a lumbar puncture and you take a sample from the CSF and you look at it. And if you find that there is a large number, increased number of tau proteins, then it's very likely that this person has Alzheimer's disease or Alzheimer's dementia. Now, this is not, this way of this technique is not used in the UK, but it's quite common in Scandinavia. In Scandinavia, even in health centers, they do lumbar punctures, and people just accept it. I don't think that happens in other parts. I'm not sure about America, but I think it's the same. People don't like invasive investigations like lumbar puncture. So it's very rarely used, unless in very unclear cases or in research centers. So that's another way of diagnosing Alzheimer's disease and Alzheimer's dementia. So these are about the lab and the neuroimaging. But before you get there, you need to do your cognitive assessment. And when a patient is referred to you or presented to you with problems with memory, you need to assess their cognition. You are not only assessing the memory, you are assessing their cognition, every part of it. Memory, understanding, language, thinking, decision making, and dexterity. And the best and the gold standard cognitive assessment we use now is the ACE, or the Addenbrooke's Cognitive Examination. Addenbrooke is the University Hospital of Cambridge University, and that's where this cognitive assessment was designed. And there was neurologists, there were psychiatrists, there were neuropsychologists who were involved into it. And they did a lot of work, and they come up with this assessment and are referred to revised. So this is the gold standard, the benchmark to assess cognition. And the ACE has been translated to many languages, including Urdu, Hindi, other European languages, and Arabic. وأخواننا المصريين عملوا ترجمة للإيس اللي هي دي، عارف إذا قادرين تشوفوها. بيقول لهم مثلا أنا هقول لك 3 كلمات عايزك تعيدها ورايا، حاجة كده، ليمونة، مفتاح، كورة، حاجة زي كده. واعتقد انه في السعودية برضو عملوا سعودي فيرشن. قبل سنوات حاولنا نحن نعمل سودنة للإيس، واتذكر في الناس اللي كانوا في الحضور، ما اعرف هم موجودين دلوقتي في الاوديوس ولا لا، الزميل الدكتور عبد الرحمن ابو دوم والدكتور خالد عبد الله، ومشينا فيه مشوارع، لكن بعد ذاك طبعا حصلت ظروف كثيرة ما نقدر نواصل فيه. ويا ريت الناس يواصلوا في المشوار ده، ويا ريت لو نقدر نعمل فيرشن سوداني من الإيس. فدي حاجة برضه أنا بطرحها للترينيز، إذا كان في زول عنده الرغبة في أنه تو كاري أون الشغل بتاعنا اللي بديناه. So the ACE is the benchmark of the cognitive assessment. The ACE, the full mark is 100 points. The cutoff score is 82. So for any person scoring below the age of 82, all you can say that this person is scoring in the dementia range. It's not diagnostic. You cannot say this person has dementia because they scored less than 82. And the same about if they score higher than 82. And like any cognitive assessment, it's can be culturally biased, can be educationally biased. So people with high education, say مثلا professor في الجامعة, if you apply this cognitive assessment to them, they might score within normal limits. That doesn't mean that they don't have dementia. And I remember a case when I was a registrar. I saw somebody who was referred to us by the GP, and she came to the GP and she said, I think my memory is not good, and I think I'm worried that I might have dementia. So I went to see her at home. She was a lecturer in physics in the university, the local university, and her husband was a professor in mathematics. So they are highly intelligent, highly educated people. And she whizzed through the cognitive assessment. He scored very, very good marks. So I took it back to my consultant and I said, I don't think she has dementia. And my consultant was good experience. She said to me, if you see this woman in 5 years, you will see that she has dementia. Although she is scoring now in the normal range, but she knows something is not right. She knows that her memory is not as good as she was before. So although she is beating the system, she's beating the assessment now, but she knows something is wrong. And it might take some time before it goes down to the level before the 82. And the same applies on the other extreme. So if somebody has, I don't know, low education or for cultural differences, they might score low on the assessment, but that doesn't mean they have dementia. And that's why I'm saying you cannot use it as a diagnostic tool. The dementia diagnosis is a clinical diagnosis. It's a cognitive assessment, cognitive decline, cognitive impairment, as confirmed by the cognitive assessment and the neuroimaging and the history from the patient or from somebody from the family. How good are we getting at getting the diagnosis right? Professor Ian McKeith in Newcastle, he did a very well-designed study. So he brought the brains of people who died, documented in their notes that they died of Alzheimer's disease. And he dissected their brains. He gave it to the neuropathologist in his department, and he asked them to look at the brains of these people without telling them what the diagnosis was. And he asked them to come up with a diagnosis, to look for the neurofibrillary tangles and the plaques. And then he compared those findings, those diagnoses given by the neuropathologist, to the diagnosis given to the patients when they were alive, and to check if the psychiatrists or the clinicians, did they get it right or not. And the result was they were right in about 90% of the cases, which means that clinically we can make a very good diagnosis of Alzheimer's dementia, which is a good result. So this is a graph to show what happens to the brain as we grow older. And as, say, we go in their 30s, 40s, 50s years, it goes down. And when it comes to Alzheimer's disease, there is a sharp decline here. And like I said, it's sort of accelerating the aging process. And what we do is we are treating or trying to treat the patients with Alzheimer's dementia at this stage. After it's become obvious, we are able to detect it, or by the cognitive assessments, or people around the patient notice it, or the patients themselves, if they're intelligent and educated, they notice themselves that something is not right. By that time, the illness has already started. Maybe a year, maybe two, maybe more, maybe longer than that. So what about, so this is this is a preclinical Alzheimer's disease. The patient don't notice anything. The people around the patient, they don't notice anything, but the illness has already started, and it takes years to come to this stage, which we call mild cognitive impairment, MCI. And that's where most people will come to us and say that we want to be assessed. And that's when it is confirmed, and by that time the illness has been established and it keeps going downhill. So what about if we can find a way to diagnose the illness here, or even here in the preclinical stage? And if you think about this, and if you compare this with somebody with cancer, for example, you don't wait for somebody with cancer to come to this stage before you diagnose them and before you start the treatment. You want to start it here, or even better, you want to start it even here. That's why we do things like routine mammograms, cervical sampling, biopsy for women, so that you can catch the illness in its very early stages and then you start the treatment. So why can't we do the same with Alzheimer's dementia? So we talk about the treatment options. In fact, treatment might not be the right word, because like I said earlier, there is no treatment unless very recently there's some hopes. Currently, the medication that's available for therapies for Alzheimer's dementia are the acetylcholinesterase inhibitors. Donepezil, the commercial name is Aricept, galantamine, Bremeniil, rivastigmine, Exelon, and memantine is Elixir. These three first here are the acetylcholinesterase inhibitors. This works on the NMDA receptor system, and it works in a different way. These are indicated for the early stages, early to moderate stages of the Alzheimer's dementia. This is licensed for the advanced stage of dementia. So what does it do? How does it work? Acetylcholinesterase inhibitors. Again, if you remember your Krebs cycle, biochemistry, we believe that the acetylcholine is the neurotransmitter that's most involved in the memory. So it's very important for a normal functioning brain to have plenty of acetylcholine. And this is the metabolism and the catabolism of the acetylcholine. Choline for the diet plus the acetyl-CoA will give you acetylcholine and CoA. And then it is broken down by an enzyme called acetylcholine esterase. It is broken down to citric acid and choline, and then the choline will go back to start the cycle again. So what happens is the acetylcholinesterase inhibitors, as the name implies, it inhibits this enzyme here. So what does that do? That means that you preserve the acetylcholine. You stop it from being broken down by the brain. So you help the brain to function, because it will not lose the acetylcholine as in a normal brain. However, there's going to be a stage where the brain itself is no longer able to produce acetylcholine. So the analog I say to my patients that this medication is like giving super benzene super لعربية قديمة. You haven't changed the engine, you haven't changed the car itself, but you gave it super fuel to make it work better. And that's why this medication has a limited effect. Even the manufacturer will say that they don't advise using it beyond 18 months, because by that time the brain can no longer produce enough acetylcholine. So see, it's not a treatment, but it's something that to help the brain to work better, and it just delays the symptoms of the dementia. So what about the future? You might have heard of the monoclonal antibodies, the MAPs, as they call it. أو في السودان بيقول لي المابات. والمابات is a flavor of the month in regarding the drug treatment, not only for dementia, but has been used for cancers, different types of cancers. But then I don't know why, لكن they have these mouthful names. اسمها يعني غريبة وصعب النطق بتاعها، بلينا تو ماب، وكلها منتهية بالماب، ماب مونو امينو monoclonal antibodies. It has been used successfully in treating cancers, certain types of cancer. It kills the brain, the cancer cells. It has been used in the treatment of lymphomas, chronic lymphocytic leukemia. It has been used in the treatment of allergies, like allergic rhinitis. And if you are like me, you suffer with allergic rhinitis, this might sound like very good news. It has also been used in the treatment of COVID-19. So the MAPs are a very promising class of drugs that might help with many difficult to treat illnesses. And it has always also been used as a treatment for Alzheimer dementia and frontotemporal dementia or Pick's disease. The one that is licensed in the UK is called lecanemab or Leqembi, which is manufactured by Eisai's company. There's others. It was all manufactured in America. And I think in 2022, it was passed by the FDA, and then it came to the UK. And last year, it was approved by the NICE, National Institute of Clinical Excellence. However, because it's very expensive, they did not allow the NHS or the National Health Services to pay for it. So for now, although the medication is available, but it's only in private clinics, so people have to pay for it. It costs about, I think, about 20,000 pounds, I think about $30,000 or something like this. So it's quite expensive. That's on one side. On the other side, the administration itself is quite tricky. It's an infusion. So the patient will have the infusion every week. So they have to go to the clinic and have the infusion. And it can have some worrying side effects. It's called ARIA, amyloid-related intracerebral hemorrhage. So it can lead to brain hemorrhage and can lead to quite serious side effects. It's very rare, but there have been reports of some patients who died because of this ARIA. So because of that, every time, every few months, the patient will have to go for an MRI to make sure that they don't have this ARIA. At the moment in the UK, it's being piloted in some clinics. One of them is in Birmingham, and I might get involved into this clinic here. And there is a debate because of the requirements of the clinic itself. There is a debate, it's an all debate about should this be done by the psychiatrist or by the neurologist? Because it has to go in certain clinics, it has to go in a clinic with certain facilities. In case something happened to the patient, you have to have access to MRI. At the moment, we are working with the neurologist to very likely it's going to be a joint clinic between the neurologist and the psychiatrist. But in any case, it's a glimpse of light at the end of the tunnel. That for the first time, we have a treatment, potentially a treatment to address the core of the illness itself. جذور المشكلة زي ما بقولوا. Something that attacks, it clears the plaques from the brain. And by doing that, you hope that you are going to stop the illness. And if you think about it, 30, 40 years ago, the same thing happened with cancer. We didn't have any treatment for cancer before, and cancer was like a death sentence. Nowadays, many types of cancers can be treated. Breast cancer, prostate cancer, so many types. But you have to diagnose it earlier, and you have to have the right medication and the right treatment for it, which is the case in the cancer. We can catch it earlier, and we have chemotherapy, we have radiotherapy, we have surgical techniques, we have so many advanced ways of treating it. The same thing is going to happen with Alzheimer dementia and Alzheimer disease. but it's going to take some time. I don't know how long, 10 years, 20 years, 30 years. I don't think, but we are going to be there to aware from it, but maybe somebody, younger people, colleagues in the audience might be there when it becomes available and better. As what happens with all types of medication before, in the start, it can be quite expensive and it can cause a lot of side effects. But as a competition, طبعا, as you know, by the way, every company, because they spent a lot of money to develop these new medicines, billions of dollars. So they're given a patent for about 10 years, sometimes 20 years, to recoup back that money. And after that, it becomes out of patent. And then everybody can manufacture it. But it will go down, the price will go down. That happens with Aricept, for example. Now, أنا عارف إنه بيصنعوه في السعودية، بيصنعوه في مصر، بيصنعوه في أماكن كثيرة جدا. The price went down and becomes like 10% of the original price when it came out in 1990. I hope that the same thing is going to happen with the lecanemab and the other maps, and gives hope for the people with Alzheimer disease and Alzheimer dementia. Thank you very much, and Ramadan Kareem.
شكرا جزيلا يا محمود. It was very nice, interesting حقيقة، وجذبت حضور كبير جدا جدا unusual حقيقة. يعني أنا شايف الحضور more than 106 لأول مرة منذ أن بدأنا البرنامج، لكن تستاهل حقيقة أكثر من كده. It was very nice. فبنفتح المجال للأسئلة. أي زول عنده سؤال please introduce yourself and ask your question. The mic is yours. بعدين بنشوف لو في أسئلة مكتوبة في الشات يا محمود بقول عليك برضه، لكن ندي في الأول الفرصة للverbal questions. تفضلوا.
السلام عليكم.
عليكم السلام.
أنا منيرة، انتهيت من التدريب. بسأل من التريتمنت الأسيتايل كوليسترول انهيبيتر ممكن يعالج البيهيفير سيمتومز أو البيرسوناليتي تشينجز اللي بتحصل، ولا بس مركز في الميموري؟
طيب، أنا ما أعرف نجاوب على اسأل سؤال ولا ناخذ سؤالين ثلاثة؟
والله أحسن يا محمود لو جاوبت طوالي يكون كويس.
أوكي تمام. طيب تمام. منيرة مش كده؟
نعم.
أيوة نعم.
طيب. شكرا جزيلا منيرة. This is a very good question. والحقيقة إنه the answer is straight yes. It helps with the behavior. And I give you an example. كان عندي patient كتبنا لها الأريسبت، وكانت يعني بتشاكل حالة سوري، هو كان ميل بيشنت، وكان بشاكل مرته، ويقول لها مثلا انا داير اطلع امشي الشغل، وهو خلص الشغل له 10 سنين، وتقوم تقول له لا انت ما شغال، وقوم طبعا تقوم الشكله تحصل ويقوم يضاربه وكده. وقاموا جابوه لنا وبدينا له التريتمنت بتاع الديمنشيا. الدياجنوز كان واضح جدا، الزهايمر الديمنشيا، وبدينا له الاريسيب. بعد 18 شهر انا قلت لها يا اخي انا عايز اوقف الدواء ده، لانه بعد ده بيبقى ما فيه فائده من ناحيه بعد جوجل الجن. قالت لي يا اخي عليك الله ما توقفه، لانه قالت لي لما اديته الاريسيبت ده الزول ده بقى هادي ورايق ومبسوط وقاعد وما عامل لي اي مشاكل. فخليه، انا دونت كير اباوت الميموري، about forgetfulness، لكن it helped me لانه he's blessed now وما قاعد يشاكلني ولا قاعد يضاربني، وانا مبسوطه جدا. فخليته استمر في الدواء بتاعه ده for about 5 or 6 years. اتعلمت من الوقت ده انه ما بوقفه حتى لو بقى ما فوق فايده من الناحيه بتاعت cognition، لكن it helps people to calm down. I strongly recommend انه to prescribe it to anyone with behavioral problems. By the way, behavioral problems is the main reason, the first reason why people with dementia going to the nursing homes. لأنه the carers cannot cope with their behavior, not because of their memory problems. But if the Aricept and other medication can help with that behavior, then why not? So the answer is yes, it does.
Thank you. Any other question, please?
أيوة يا بص السلام عليكم.
تفضل. السلام، تفضل.
طيب أنا حسين أرتو. يا بص أنا عندي تو كويشن. أنت في بداية المحاضرة في النيورو راديولوجي كان قلت لنا إنه السي تي أفضل من الام ار اي، فأنا الحاجة الفاهمة إنه السوفت تيشو إحنا عايزين نشوف السوفت تيشو بتكون الام ار اي أحسن، فعايزك توضح لنا النقطة دي من خبرتك، ليه السي تي أفضل من الام ار اي مع إنه إحنا عايزين نشوف سوفت تيشو. الحاجة الثانية يا بص بالنسبة للمونوكلونال أنتي بوديز، هل بتنفع لو أديناها بعد المايلد كوجنيتيف امبيرمنت، يعني بعد الام سي اي ديفلوبد وخلاص ويل استابليش دايجنوزس اوف الزهايمر، ولا كده خلاص بيبقى تولد؟ وشكرا لك جدا، فيري نيدد لك والله.
شكرا جزيلا. اوكي، السي تي سكان انا قلت افضل لانه it shows structural changes في البرين. و what we are looking for in Alzheimer dementia is structural changes. زي ما قلت الشرينكيج and الاتروفي بتاع الهيبوكامبس ده is better shown by the CT scan. I'm not very much interested in the soft tissue. The changes in the soft tissues in the brain are at microscopic level, so I can't see it on a scan. Lakin I can see the change in the volume of the hippocampus better with the CT scan. The CT scan is cheaper, is easier to يعني أسهل. And it gives me better results. That's why I go for the CT scan more than the MRI. The second question, the MAPS, is it given in the mild and to moderate stage? Yes, it is. أصلاً this is a plan. Once the diagnosis is established, then you start the treatment. Something else I haven't mentioned, there is a new scanner now, which can detect the plaques in the brain. So you don't have to open somebody's brain to see if there is plaques or not. There is this scanner, which you send your patient to, and it will tell you that there is a higher number of plaques in this brain. So even you can argue, theoretical at least speaking, you can argue that patient is going to develop Alzheimer's disease in the future. And you can give them the choice. Do you want to start the treatment now? It's just like telling somebody, you are going to have cancer in 5 years. Do you want to wait until the cancer starts and it is confirmed and established, or do you want to start the treatment now? It's a difficult question. Lakin, yes. And I think this is where the future is going to be. Given this new imaging, the plaques scanners and the treatment availability, then there's going to be a way to catch the illness even before it becomes apparent, before it becomes symptomatic.
السلام عليكم.
عليكم السلام.
مصعب إبراهيم R2. والله this debate, what's the role of psychiatrist in dealing with Alzheimer's disease, and what's the role of neurologist? And first, to be seen by psychiatrist or neurologist, I want to clarify this point because facing us too much in clinical setting.
Yeah, شكرا يا مصعب. برضه سؤال مهم وسؤال very relevant. Actually, the two specialties are getting closer and closer all the time. And دكتور عبد الغني بيتذكر مرة كنا في حلقة في التلفزيون، كان معانا أستاذ مرغم عبد العزيز، وقال لنا إنه النيورولوجي الوقت غيروا اسمه، نسيت سموه شنو يا دكتور عبد الغني، لكن ما معناه إنه بقى حاجة قريبة من السايكاتري، والسايكاتري بقى حاجة قريبة من النيورولوجي. يعني حس الكلام اللي أنا قلته ده فيه كلام كثير جدا عن من النيوروناتومي، من البايوكيمستري، يعني فيزيكال ميديكال ستاف. فبيبقى بعد ذاك الكلام بتاع انه it is going to be under the psychiatrist or the neurologist. زي ما قلت حاسه التريتمنت الجديد ده في برمنغهام في نقاش زي ده يعني. the way forward إنه we work together. تكون في joint clinic between the neurologist and the psychiatrist. And in fact, this already started. يعني نحن عندنا في old age department بتاعتنا في Birmingham, we do a monthly meeting with the radiologist and the neurologist. And we discuss the CT scans, we discuss the MRI scans, we discuss cases. So we present it from our side as psychiatrists, whom they chip in from their side as neurologists, neuroradiologists, and neurologists. And this proved to be very, very useful, especially in borderline cases where you are not sure, is this dementia, is this something else? The neurologist can help you, the radiologist can help you, and we work together. So I think this is a way forward, that this is where it's going to be. There's going to be joint clinics and joint teams between the 2 or 3 specialties: psychiatry, neurology, and radiology.
Yes, شكرا محمود. يس، إجابة وافية. والديبيت ده ذاته يا محمود ويا مصعب في الإبيليبسي برضه، لو تتذكروا دائما الديبيت إنه الإبيليبتيك patients with epilepsy are they treated by a psychiatrist or a neurologist حتى الدايجنوزيس. فأنا أعتقد زي ما قال محمود هو conjoint، لكن السايكايتريست can give better service I think، لأنه في الألزهايمر أو في الديمنشيز عموما يا محمود زي ما أنت قلت لنا we can prescribe antipsychotics sometimes in a small dose, quetiapine, or some people can prescribe risperidone for sleep problems, behavioral, sometimes anger issues or aggressive tendency. Neurologists, they are not so familiar with the antipsychotics. نفس الحكاية الإبيليبسي بيكون أحيانا معه psychotic symptoms or behavioral problems برضه. what about the role with antipsychotics يا محمود, small doses of antipsychotics to patients with Alzheimer dementia?
Of course, Alzheimer dementia can be associated by behavioral and psychological symptoms, or we call it BPSD, behavioral and psychological symptoms of dementia. And these range from aggression, agitation, to visual hallucinations, to paranoid delusions, and depression. So this needs to be treated by psychotropic medication, depending on the symptoms profile itself. So it can be antipsychotics, it can be antidepressants. And because I deal with elderly patients, I commonly prescribe antipsychotic medication. ومعظم البيشنتس اللي بيجونا في الوورد بيجونا مش زي ما قلت قبل، مش عشان الكوجنيتيف ديكلاين، لكن عشان البيهيفير بتاعتهم. Many of them will present with psychotic symptoms, visual hallucinations or paranoid delusions. My favorite antipsychotic is quetiapine for a number of reasons. It's a low potency antipsychotic, so you can prescribe a very small dose, like 25 milligram, and you can build it up gradually. I don't think I need to use more than 100 milligram, which is, compared to the other services, a very tiny small dose. The other good thing about the quetiapine is that it's sedating, so it calms the patient down, and I have very good results. Going back to what you were saying earlier يا عبد الغني، هو ده الحاصل في الحقيقة. Patients with dementia they come to us by default، لأنه النيورولوجيست ما عايز إنهم زي ما قال واحد في الشات، لأنه بيعمل لهم مشاكل في الوورد، يقلعوا الكانيولا من البيشنتس التانيين ويضربوا النيرسز وكده وبتاع، فيقوموا يقولوا لنا تعالوا شيلوهم وخذوهم عندكم، فباي ديفولت هم حيجوا عندنا أصلا. لكن احنا برضه بنحتاج الانبوت بتاع النيورولوجيست والراديولوجيست اللي قدام في التريتمنت وفي المانجمنت. لكن the psychiatrist will take the lead في المانجمنت بتاع الديمنشيا because of the behavioral difficult behavior of the patients. So that's a little right.
Thank you so much. فتحية سعيد، اتفضلي، شايفك raising your hand، اتفضلي.
اوكي، ده اسال دكتور بشرى عن الاكتيف اميونوثيرابي اللي هو زي الفاكسين كده. هل الحاجة دي موجودة هسه حاليا وهو is targeting، يعني احنا بعدين لو موجودة بعدين وتوجدت احنا مديها لمنوع عشان تكون مفيدة أكتر؟
انا هكون اول ذر هاخدها. اذا اتوجدت طبعا. والله دي حاجه I don't know if anyone thought about it، لكن it's a good idea. الوقايه خير من العلاج، مش كده؟ You don't want to wait until the illness happens وبعدين you treat it. If you can protect people from having the illness itself، ده هو عاوزينه نحن كلنا. لكن as far as I know there is no any work on vaccination simply because like I said we don't know what causes the illness itself. This is a problem with most mental health problems and psychotic illnesses, depression. We are scratching at the surface. We don't know what happens in the brain. يعني psychiatry is leading behind many other specialties. There's so many advanced surgical techniques ومedication وغيره في other specialties. لكن because we deal with the brain, we don't know how the brain works. We don't know how the normal brain works to find out what happened in the abnormal brain. If we do, then we can find ways of protecting the brain from having the illness and causing the vaccination. Yes, it's a very good idea. Maybe if we're around in 100 years, maybe there's going to be vaccination against dementia.
Thank you. Thank you. تفضل يا خلف الله وبعده عامر عبد الرحمن. تفضل.
السلام عليكم ورحمة الله. خلف الله R1. My question يا بص إنه about ال MME أو mini mental state examination. هو كثير قاعد أشوفه مع يعني لما أقرأ عن الديمنشيا بقرأ عنه، يعني بلقاه موجود. فعلاقته شنو بالتشخيص؟ هل هو useful in diagnosis أو ولا هو for other purposes؟
شكرا جزيلا. ذكرتني بموضوع MMSE ده لانه مهم جدا. انا كنت عاوز اذكر يعني الميني منتال ستيت اكزامينيشن كانت هي الكوجنيتيف اسسمنت اللي مستعمله للاسسمنت اون ذا بيد سايد تو diagnose dementia. وزي ما كنا عارفين ان هي زي كم سؤال 10 اسئله ولا كده، والسكور الفاينل بتاعه 30. وكان المعروف انه if the patient scores less than 24 then you say they are scoring in the dementia range. We don't use it now. وانا كنت عايز انبه للحكايه دي. We don't use it and I would not advise anyone to use it because what happened انه في واحد في استراليا قال انه MMSE دي حقتي و anyone who is using it will have to pay me copyrights. So if you mention it in a study or research or you publish it ولا حاجة زي كده, you make yourself open to be sued يعني. So what do we do? لو رجعنا للACE اللي أنا ذكرته قبل، الصفحة الأولانية منه هي الميني ACE which is now what we are using in place of the MMSE. وهي طبعا يعني فيها نوع من التحايل كده، يعني هي برضو عشان الناس بيجوا عارفين MMSE ومتعودين عليها برضو they follow the same system. So total score is 30 والminimum score cutoff score is 24 still. So anyone scoring say 20 out of 30 في الميني ACE, you will say that they are scoring in the dementia range, and then you go for further assessment and investigations. So MMSE كانت هي screening tool، يعني هي البداية. يعني زي مثلا انت شغال GP او شغال في medical ward او شغال ما في specialized psychiatric clinic وجاك زول you suspect انه عنده dementia, you do mini ACE, and if you think that they might have dementia you refer them to the specialist services زي ما كنا نعمل زمان مع MMSE. فالMMSE is no longer يعني available to be used، لكن الريبليسمنت بتاعه هو الميني ACE اللي هو زي ما قلت الصفحة الأولى من الفول ACE assessment.
Thank you. No longer يا محمود because of the legal issues ولا because it is not that valid.
No, just because of the legal issues.
legal issues. طبعا الليجل ايشوز في السودان احنا ما شغالين بها الان لسه ولا زول بيقدر يحصلنا من استراليا ويشتكينا، ولو اشتكانا ما في زول بيشتغل به. شغالين به الحقيقه، بل ترجمناه يا محمود نحن قبل 10 سنين ولا كم ترجمناه بالسوداني انا ودكتور عبد الله عبد الرحمن وعندنا منه سودانيز فيرشن مترجم الحقيقه.
اوكي طيب
نعم.
طيب اذا كان كده ليه ما يعني عشان الحكايه تبقى اسهل ليه ما نعمل ترجمه للميني ايس؟ الميني ايس ما بيختلف كثير على الام ام اس اي بالمناسبه. فممكن
ممتاز.
الخطوره بتاعت زي ما قلت انه لو عملت بابليكيشن وذكرت فيها ام ام اس اي ومشت في جيرنال برا
نعم.
you find yourself in troubles.
Absolutely. Thank you for this answer. طيب عامر عبد الرحمن وبعده هدي القشي وبعده لا عامر عبد الرحمن وبعده فتح العليم وبعده هدي القشي. تفضلوا. تفضل يا عامر.
بشرى.
يا اخوان اقفلوا الناس اللي ما ينفولد اقفلوا المايكات في شكلها مدوره بين الاطفال ولا حاجه. يس واصل. تفضل.
أول حاجة thank you so much for this informative lecture. أنا عامر عبد الرحمن R4. حقيقة عندي سؤال بس في بالنسبة لل APP والتاو بروتينز. as you said before إنه مستر ألويس الزهايمر هو من بدأ يعني بدأ discovery of these diseases since that time. هل في ابديت؟ لانه as you said انه اللي هو بكون فيه لاحظ انه في بريكسرز بتاعت الاميلويد والتاو بروتينز، فنحن depending on الديسكفري دي since ممكن a century ago. my question انه اذا انا مثلا عملت diagnosis مثلا وحصل clinical diagnosis for Alzheimer patients without انه اشوف مثلا في APP او تاوز في CSF. is it possible الكلام ده، ولا ممكن في patients without او negatively APP and tau with clinical manifestations of neurocognitive decline في الالزهايمر؟ لانه انا بشوف انه هل في updates about anatomical discovery before؟ يعني نحن depend on a person 100 years ago. ما أعرف أنا أكون وصلت الفكرة يا دكتور محمود.
بحاول أجاوب قدر ما فهمت من كلامك. أول حاجة أنا قبل ذكرت النقطة دي، إنه الرغم إنه الفايندينجز بتاعت الزهايمر الديagnostic فايندينجز بتاعته ما زالت لحد الآن هي الهول مارك الباثولوجيكال هول مارك تحت الديزيز. ما قدرنا نضيف عليه اي حاجه ثانيه زياده، لانه هو بس يعني دي الحاجه الموجوده في البرين بتاعت الزهايمر بيشنت. واذا كان الاجابه على سؤالك، اي زول عنده الزهايمر ديمنشيا بيكون عنده بلاكس ونيوروفيبريتانجز. اذا ما في بلاكس ونيوروفيبريتانجز this is not Alzheimer, this is something else. لكن الإجابة على سؤالك حسب ما فهمت إنه do I have to find plaques في CSF عشان to diagnose Alzheimer? No. زي ما قلت نحن هنا في اليو كي we don't do lumbar punctures. لكن we do diagnose Alzheimer dementia. We get it right about 90-95% بالclinical history من البيشنتس أو من الفاميليز الكيرز بالنيورو ايميجينج بالكوجنيتيف اسسمنت.
إذا نعتمد على findings بتاعت بيرسون century ago، يعني ما هل في updates انه مثلا هل في يعني نيو مثلا يعني evidence انه في بليكس as he said، يعني الشخص اللي مثلا قبل 100 سنه او 150 years ago. يعني انا شايفه كده، بس بشوف انه في possibilities. نعتمد على كلام اوكي هو از جيرمان دكتور ما اعرف آه، وجد واكتشف اكتشاف عظيم، لكن هل نحن بنعتمد على يعني 150 سنه في الاي بي بي والتاوز، او مثلا العلم له كلام اخر يعني بالنسبه لي الفيجر
والله
الفسيولوجي.
يعني ما هو الزهايمر ما هو الوحيد اللي وصف حاجة ولازم احنا بنسبيها لحد الآن. باركنسون ديزيز مثلا، باركنسون ديزيز ده وصفه دكتور باركنسون أدونه قبل كم 100 ولا 150 سنة، لكن ما زال الدياجنوز بتاعه والساين ده السيمتومز بتاعت باركنسون دكتور باركنسون ده ما زال احنا نستعمله لحد الآن. ما في حاجة بتمنع، ما هو ده الفايندنجز تحت الموجودة في البرين. يعني ما في حاجة تاني تو يعني تو داوت ات. يعني هو وصف illness وسموه بعد ذاك باسمه الزهايمر ديزيز، ونحن قاعدين نتكلم عن نفس الإلنس اللي هو اسمه الزهايمر ديزيز، ودي الباثولوجيكال ماركس بتاعته، الباثولوجيكال فايندنجز بتاعته. فكونها لها أكثر من 100 سنة، ما في حاجات كثيرة في الميديسين لها 100 200 سنة يعني. باستير اتكلم عن الانتيبايوتكس، الكسندر فليمنج اتكلم عن حاجات كثيره جدا حصلت من زمان، لكن ما زلنا احنا ماشيين بها لانها حاجه صح. يعني مش لانها حصلت قبل 100 سنه اشكك فيها. لكن التطور بيجي بعد ذاك بانه اوكي this is the findings, this is the illness, how do we treat it, how do we manage it, how we prevent it, how we stop it from happening in the first place. ده بيكون هو التطور المفروض نحن نركز عليه يعني.
ثانك يو محمود. فتح العليم اتفضل.
فتح العليم محمد عثمان R4. الحقيقة عندي استفسار فيما يخص الكولين ستيريز انهيبيترز الدومبيزيل مثلا، انه مثلا احنا بنديه تمبروف الكوجنيشن مثلا في كل الستيجز بتاعت الديسيز، لكن الريزلتس برضه كويشنبل. فاذا مثلا ادوها مع الميموري سبليمنتس زي مثلا الاوميجا فاتي اوميجا 3 فاتي اسيدز مثلا، هل بتدي بيتر افكتس مثلا ولا ما يعني ما في فايدة منها؟
Okay, that's also a very good question. أنا الحقيقة ما تكلمت عن الحاجات الثانية، الأوبشنز الثانية بتاعت الميموري. أول حاجة just to clarify إنه acetylcholinesterase inhibitors it does not improve the memory. This is not the function of it. In very few cases we have seen some improvement in the memory. لكن this is not what it meant to do. What it meant to do زي ما قلت إنه to preserve as much as acetylcholine in the brain. So it's not producing new acetylcholine. It's just stopping the brain from losing it quickly. عشان كده even the manufacturer بيقولوا إنه it delays الsymptoms بتاعت delays the progression of the symptoms of the illness, not improve it. There is no evidence that it is improved. In most cases, we don't see improvement. لكن we see as a plateau so far. هم المانفاكتشرز بيقولوا for 18 months. بعد 18 months بيقولوا it doesn't work. It is only licensed for mild to moderate Alzheimer dementia. It's not licensed to be used in severe dementia. إلا في الكيس اللي أنا قلت البيل بتاعت المرة جاتني قالت لي ما توقف الحبوب من الرجل لأنه البيهيفير بتاعه اتغير بعد الاسيتايلكولين انهبيتورز. في الحاله دي انا ام بريسكرايبنج الدونابازيل مش عشان الكوجنيشن. it's no longer a cognitive enhancer. It stops doing that role. لكن it helps with the behavior. In that case, which is out of license, I continue. الميمانتين هو is another drug that is licensed to be used in the advanced stage. In my hands, I don't find it very useful. Once the dementia is established, it's going to go downhill, it's going to go to progress, and there's nothing to stop it. Only the acetylcholinesterase inhibitors can help with the behavior. Like I said, the only hope now is the MAPS, which again, it has to be started early in the illness. Once the illness is established, the damage is already done. It has killed billions and billions of the brain cells. And we know that if the neuron dies, there's nothing that can bring it back. So it doesn't work. No medication can work in the advanced stage. It's too late.
Okay.
Thank you, إبراهيم. تفضل يا ندى. هديل قشي.
السلام عليكم. هدي القشي F3. شكرا جزيلا دكتور محمود، دكتور عبد الغني. أنا سؤالي عن sexual disinhibition and dementia. best approach اللي هي سواء non-pharmacological أو pharmacological from your experience.
again دي برضو يعني حاجة very important و one of the most very difficult يعني types of behavior for the family. disinhibition يعني الراجل الكبير بده يتكلم كلام ما مقبول قدام أولاده الصغار ولا قدام الناس التانيين وكده، وده جزء من البي بي اس دي اللي قلناها قبل اللي هي behavioral psychotic symptoms of dementia. ما في specific treatment لها. how do you respond to it? Again يعني صعب الواحد يدي إجابة واحدة. ومرات كتير جدا بتأدي طبعا لكلاشز ولارجيومنتس، ويعني هو ما بيكون شاعر بأنه هو بيعمل في حاجة غلط يعني، لكن بيكون حاجة محرجة طبعا للفاميلي وكده. I don't know يعني if I'm pressed I will say a small dose of quetiapine might help، لكن يعني there is no specific treatment for it. it's one of the difficult situations. برضو واحدة من ال difficult situations إنه what do you do لما الزول المريض بالديمنشيا يقول لك مثلا إنه أنا ما فطرت، ما جبت لي فطور ليه؟ هو يكون فطر له زي نص ساعة. هل تقول له أنت فطرت؟ هيقوم يغالطك وهيقوم يزعل لما تقول أنت فطرت، لأنه هو بالنسبة له ما فطر. he's gone خلاص، he's lost الميموري بتاعته دي يعني. فهل تخلي الصينية بتاعت الفطور قدامه عشان هو يتذكر انه هو فطر؟ different people dealt with it in different ways. لكن في situations كثيرة جدا يعني الناس بتاع الديمنشيا او الناس حتى سايكوتيك مثلا يعني الناس اللي عندهم delusions وكده يعني it's very difficult to give one answer. It depends on the situation, it depends on the interaction and the family dynamics itself. لكن it's a difficult one.
طيب دكتور معلش، احنا كنا في الحالات العادية sometimes بنستخدم الانتي اندروجينز، بنستخدم بعض ال SSRI. Shall we do this with the patient اللي عندهم dementia or it should be بس يعني مثلا behavioral modification أو مثلا بس إنه الناس تحاول إنها to control ال behavior.
androgens تقصدي يعني for sexual dampening down يعني؟
Yes. Is it an option for them?
No, I don't think it is, or I wouldn't advise using it for an elderly person. SSRIs, again, هنا يعني we are going into an area where there is no research, there is no proof. I know, for example, people with frontal lobe dementia اللي يمكن نتكلم عنها في lecture تانية، لأنه it is dominated by behavioral disinhibition. People have tried anti-epileptic medication with good results. Again, it works. For some people, it doesn't work. I tried antipsychotic medication. I got different results. With some patients, it worked. With some patients, it doesn't. Yes, so it's a gray area. You can try, but the anti-epileptic medication, carbamazepine, sodium valproate, it has been tried with some success in frontal lobe dementia. And so it might work in disinhibition related to Alzheimer dementia.
شكرا دكتور، يعطيك العافية.
Thank you. تفضل يا إيمان عمر الطيب.
السلام عليكم، أنا إيمان عمر الطيب R2. My question is about acetylcholinesterase inhibitors. To what extent they help in activity of daily living في Alzheimer's disease. وتاني بسأل عن الavailability في السودان والبرايسز، ما عندي فكرة، فلو وريتنا معلومات عنها يديك العافية.
اوكي، زي ما قلت قبل إن هي أساسا to preserve acetylcholine neurotransmitter، وده is associated with the work of the memory specifically. It doesn't improve the memory لكن it might preserve it and might maintain it. هل ده بينعكس على activities of daily living؟ Probably yes. It's not going to improve it لكن it's going to maintain it for some time. يمكن ده it helps in that regard. as الابيليتي بتاعتها في السودان يس موجوده، وانا ذكرتك بين انه موجوده في شركه سعوديه اسمها تبوك يا عبد الغني، هي بتعمل الريسبت عنده مسمينه اسم ثاني، لكن
نعم
موجوده في السودان. في السودان قبل الحرب طبعا،
نعم
لكن موجوده
موجود.
ورخيصه
اما
افتكر.
اسعارها ما في اسعار ثابته في السودان، وما في زول هسه يقدر يقول لك اسعارها كم. اسعار العيش ما ثابته، خليكي الادويه دي.
yeah.
لكن available. Yes. Any other questions? في سؤال من ملاذ محي الدين في الشات. What about paracetam?
Sorry?
What about paracetam? paracetam ده انت عارف بيستعملوه في السودان لاي زول بس يكون عنده حتى عدم تركيز يقول له خد بيراسيتام. هو شنو انا ذاته ما عارفه. I have never prescribed it. بيراسيتام سمعت بيه يا محمود؟
No.
امم
هو شنو
بيدوه
كيلر يعني ولا؟
معلش البيراسيتام بيقولوا تمبروف اوكسجينيشن اوف ذا برين، لكن ما في اي مصدر او ايفيدنس بيس بأيد الحكايه دي. انا شخصيا برضه ما قاعد اكتبها زي بلاسيبو يعني، مع انه النيورولوجيست والفيزيشن بيكتبوا كثير وكده يعني.
شكرا حمد فعلا، ولكن انا I have never prescribed it. ولكن بيجونوا بيشنس كثيرين فعلا يا محمود ويا حمد هم demented وكانوا مشوا لفيزيشنز كاتبين لهم بيراسيتام يقول لك ده بنستعمله، لكن اصلا ما شفنا له اي فائده ولا كتبناه الحقيقه. it has no evidence that.
شكرا حمد، وكويس انه انت موجود، يعني كويس انه الواحد يسمع صوتك. في الحقيقه يعني هو الديمنشيا has nothing to do with the level of oxygen in the brain. يعني it's not hypoxia. This is something totally different. فما عارف اذا كان في حاجه تمبروف الاكسجينيشن بتاع البرين. how does it improve الزهايمر disease.
ولا حتى الاكسجينيشن هو does not improve. والله بلاسيبو ساكت بيدوه، لكن الفيزيشنز يتعودوا يدوه بصوره كثيره لاي زول كبير في العمر، ده بيزيد الذاكره، بيصلح الذاكره زي ما قال دكتور حمد، فهو has no evidence.
unfortunately انا شفت يعني on personal level ناس من اهلي يعني عندهم الزهايمر ديزيز، الزهايمر ديمنشيا، والناس دائما بيمشوا للنيورولوجيست ما بيجوا للسايكاتريست for a number of reasons يعني. وبيمشوا للنيورولوجيست وبيعملوا لهم سي تي سكانز وام ار ايز واي اي جي وحاجات كلها ما في داعي ليها، ما محتاجين ليها خالص. وبعدين يكتب لهم فيتامين اي ويكتب لهم مالتي فيتامينز ويكتب لهم الدواء اللي قلتوه ده ويكتب لهم حاجات كثيره جدا. there is no evidence انه this is going to do anything. بعدين في الاخر لما تبقى فيها الحكايه behavioral problems وكده بتاع they come to the psychiatrist، بتكون too late يعني. في طبعا يا ما صح.
ثانك يو. طيب افتكر احنا قربنا. يلا مصعب ابراهيم. مصعب.
بص بس انا في ملاحظه كده كان بالنسبه في بيشن كده بياخد الفيرست جنريشن انتي سايكوتيك فور لونج تايم وبيعمل لهم كو بريسكريبشن اوف انتي كولينرجيك. والاسيتايل كولين هو كروشيال يعني ميمورايزيشن اند ميموري يعني. هل في ايفيدنس يعني يكون الكو بريسكريبشن اوف انتي كولينرجيك فور لونج تايم ويز فيرست جنريشن انتي سايكوتيك خصوصا مع الالدرلي يعني to prevent breakdown of acetylcholine.
الإجابة المباشرة شكرا. الإجابة المباشرة لسؤال no, there is no evidence. لكن الأسيتايل كولين ستيرويد inhibitors عنده other uses other than a cognitive enhancer in dementia. For example, psychotic illnesses secondary to anti-Parkinsonian diseases. You can't give antipsychotics because it makes the Parkinson's disease worse. So we have tried acetylcholine steroid inhibitors to treat those patients presenting with psychotic symptoms of Parkinson's disease, and we got some very good results. So that's another use of the acetylcholine steroid inhibitors. And that's another thing that we work together with the neurologist. بيدوهم L-DOPA. They develop psychotic symptoms, in particular very bad visual hallucinations. فبقوم يحولوه لنا في السايكاتري. طبعا لو اديته اي انتي سايكوتيك بالذات الفيرست جنريشن it's going to make their Parkinson's disease worse. So it's a difficult situation, and we have tried the acetylcholinesterase inhibitors and we get some very good results. In that regard, yes, but not as an adjunct to first generation antipsychotic. No.
Thank you, Mahmoud. في another question في chat من آفاق إبراهيم. I want to ask about the mortality rate and causes of death in untreated Alzheimer's disease rather than the risky behavioral changes. I want to ask about the mortality rate and causes of death in untreated Alzheimer's disease rather than risky behavioral changes.
Okay, all right. That's a good question. زي ما قلت قبل إنه people die with dementia, not of dementia. الديمنشيا ما بتقتل، لكن الناس بيموتوا بأسباب تانية. The commonest cause of death in Alzheimer's dementia is chest infections، بالذات في الشتاء. هنا في الويست ايلاند قال يعني ناس بيموتوا باعداد كبيره جدا في المستشفيات وفي الكير هومز، بالذات الناس اللي عندهم ديمنشيا. يمكن لانه يتلوث الاميونيتي، they become weaker for some reasons. لكن people don't die. Alzheimer's dementia or any types of dementia does not kill people. So we cannot talk about the mortality rate. لكن they die of recurrent chest infections.
Thank you. Yes. يعني لو البيشنت بمعنى كلامك إنه البيشنت he was healthy and well cared of, they can live with this dementia for 10 years مثلا، لأنه زمان بيقولوا لنا الديمنشيا within 5 years they die. بتذكر لما درسونا بدري قبل 100 سنة قالوا لنا within 5 years when diagnosed, after diagnosis they die within 5 years يا محمود.
Yeah, average. وطبعا depends what type of dementia. في types of dementia people will die within 2 or 3 years. منها ل early onset Alzheimer dementia أو Lewy body dementia. لكن ال late onset dementia, I have seen people alive after 10 years. I heard about people who were alive after 15 years. They're still alive.
Yes.
Mind you, by the time the patient is diagnosed with Alzheimer dementia, the illness have already started 2, 3, maybe 4 years earlier. So you can add that. You can say sometimes people live up to 15 years.
Yes. Good. Tamam. I think I don't see any hand raised and I don't see any chat question في الشات. ياسر الليلة ما سمعنا صوتك.